My name is Lynette Chee. I work at the Royal Melbourne Hospital and Peter MacCallum Cancer Centre. We are now one single clinical service and is part of the Victorian Comprehensive Cancer Centre. And I'm a clinical hematologist as well as a bone marrow transplant physician. It includes myeloproliferative diseases, acute leukemia, and I also do allogeneic stem cell transplants. Myeloproliferative neoplasms is a clonal disorder in which there's an increase in the myeloid production in cells in the bone marrow. And that means that you can have an increase in platelets, increase in white cell counts, or increase in red cells. And there's also another related condition called myelofibrosis in which there's scarring of the bone marrow, which then leads to a reduction in these blood cell lines. Obviously, myeloproliferative neoplasms covers a whole plethora of diseases, but in 2005, the mutation JAK2 was detected in myeloproliferative diseases, which gave us a marker that was informative, which was diagnostic of the disease, which was very useful. And in 2013, there was a further breakthrough in detection of another mutation called calreticulin in those patients with myeloproliferative diseases who do not have the JAK2 mutation. So that helped very much in the diagnosis of the disease. And subsequently, the ruxolitinib, which is a JAK1 and 2 inhibitor, has come onto the market for treatment of higher risk myelofibrosis, which has shown a lot of improvement in splenomegaly as well as reduction in symptoms. That has been very beneficial for patients with the underlying condition. In myelofibrosis, in comparison to polycythemia and essential thrombocythemia, the median survival and clinical outcome is not as good, especially in the higher risk disease because of complications related to the cytopenias or the drop in the blood counts, as well as the risk of leukemia transformation. The only cure we have is with allogeneic stem cell transplantation, but unfortunately, because of the older age of presentation of these patients, not everyone is eligible to do that, to have that procedure. And even in those who do have the allogeneic stem cell transplants, the risk of toxicity associated with it compared to allogeneic stem cell transplants for other underlying hematological conditions is higher, mainly because of graft failure, in which due to myelofibrosis, enlarged spleen, and also increased graft versus host disease. So I think there's definitely room for improvement in the future for how can we improve the outcomes after allogeneic stem cell transplant for patients with myelofibrosis, be it using ruxolitinib before or after treatment, and also trying to work out how to reduce the inflammation and that's induced by the cytokines with this disorder, which is likely related to the increased graft versus host disease risk as well. Allogeneic stem cell transplantation, to consider it, we have to look at the disease-related factors, patient-related factors, and donor-related factors. So, in the disease-related factors, we would consider in someone with higher risk disease in which you expect an inferior survival as well as increased risk of leukemia progression. Because then the risks of the procedure would then be less than the benefits, i.e. the benefits will outweigh the risk. Okay, as opposed to doing it in someone with lower risk disease. Then there's the patient-related factors as well. So is someone fit enough to proceed with it? Obviously, if they've got other medical issues which preclude the use because it's a fairly toxic procedure, then they may not be eligible to go through with it. And that's why it's usually reserved for the younger, fitter patients. And number 3, do they have a suitable donor? Because obviously, if you do not have a matched donor, then you can't proceed with the transplant. And what it involves is giving conditioning chemotherapy, which is strong intensive chemotherapy, to essentially ablate the stem cells in the bone marrow before you then replace it with newer stem cells from your healthy donor, which will usually take a couple of weeks before it engrafts or takes into the patient's bone marrow to start making new cells in the blood. And because you are transplanting someone else's cells, no matter how matched they are, there's always a risk of an immune reaction called graft versus host disease, which can happen later on. So therefore, patients will need to take immunosuppressants to reduce that risk. So the added toxicity of the conditioning chemotherapy as well as immunosuppressants that we give you to treat or to prevent graft versus host disease would therefore increase your risk of infections and graft versus host disease, which are the main toxicities associated with the transplants. With regards to myeloproliferative diseases, it would be, what is it? So you have to explain it in simpler terms so that people can understand that it's caused by increased production of myeloid cells. What is the prognosis? So how will I do in the long term? And how do you treat it? Will I be cured from this or not? Common questions that I get. With regards to myelofibrosis, the median survival is approximately 6 years, but obviously it varies depending on which risk group you are. The only curative procedure is that of an allogeneic stem cell transplantation if someone is transplant eligible. However, the high-risk disease can access this drug called ruxolitinib, which is a JAK1 and 2 inhibitor. And although that does improve your symptoms, it does reduce your spleen size, and may have some effect in improvement in survival overall. However, there's loss of response as well that happens. So therefore, it's not actually considered a cure, so to speak. And therefore, the focus, if someone is not transplant eligible, is mainly on symptom control and improving their quality of life, reducing their transfusion dependence, which will reduce their visits to hospital, and they'll obviously improve their quality of life as well. I think it's very important. My patients particularly find it useful to speak to other patients and families who have similar conditions. Leukaemia Foundation is a good resource because they've got written material and they can also put you in touch with patient groups. And for MPN, there's also the MPN Alliance group that's very useful and beneficial as a source of information and also support for family and friends.